We decided to implement our stratified follow-up for high-grade lymphoma patients for 3 reasons really. The first one being NICE guidance says that patients with high-grade disease should only be followed up really for 2 years now, and at that point we should enable patients to be discharged and have the tools to deal with their lives and live everyday living well really. Secondly, we needed to look at ways of reducing our very oversubscribed clinics. We have patients are living much longer now with lymphoma, and they're on more treatments, and therefore we are seeing more patients or more appointments in clinic. So to enable us to discharge patients at a timely fashion will enable other patients who actually need the time to be in clinic to have their allotted time with the clinician. And thirdly, the way that we approach this fitted in very well with the personalised care element. We've done it as a twofold approach, looking at giving patients holistic needs assessments at the end of treatment with a treatment plan associated with that, which is given to the patient and to the GP. And then for those patients with high-grade disease, we would then follow them up for 2 years, and then at that point we would discharge them back to the care of their GP with the ability for them to SOS back to the clinical nurse specialist should they need any further care and attention. And at that point they are invited to a patient education programme to enable them to live well. So I think it's been good, as I said, for both patients who have actually been discharged, because they now we're giving them the tools to be able to live their lives well, to know what to look out for, to not be constantly worrying about whether their lymphoma is returning, but also to give them the safety net that if they have got a problem they can come back and call us at any time and we will get them straight back into the hospital system. And I also think for the remaining patients who come to clinics, their waiting times are shorter. They actually get to spend the time that they actually need with the doctors and the nursing teams without being rushed. So it's a win-win really for everybody. Probably time really to actually implement the project. It's multifaceted. There are a number of people that you need to engage with, clinicians, administrative staff, our supportive staff who work over in the Robert Ogden Centre, commissioners, our lead cancer nurse. Everybody has had a role within this, and trying to get everybody together in one room is always difficult, but also sometimes just the little things are tricky as well. So for example, trying to get our new clinic proformas done so that patients are allocated to the right clinic or to the right discharge programme. All of those things are quite a challenge, and somebody really needs to be there to make sure at each step that things are being implemented, otherwise it could easily fall by the wayside. I would say pick a group of patients that your follow-up, your stratified follow-up would fit in well with. So we picked our high-grade lymphoma patients because they are an eminently very curable group of patients who we know may relapse within the first, we know if they're going to relapse, would relapse within the first 2 years of treatment, and after that their chances of relapse are very low. So pick a group of patients where that you can work with and that you know the system will actually work with.